Good afternoon. I'm Dr. Sarah Smucker-Barnwell, and I'm so glad you're able to join us for today's webinar. As a trust policyholder, you may be familiar with our telehealth community chats. I'm so pleased to be once again joined by Dr. Margot Adams-Larson to present number 24 in our series. In the interest of time, our bios have been placed on a slide for you. So without further ado, let's get started. Margot, it's great to see you, and I can't believe we're on chat number 24.
It is pretty amazing. These are my favorite times of the quarter to get to chat with you, Sarah, and to hear what's on people's question minds as we go through our telehealth community chats. And just as a reminder, we're here as just a practical how-to information from ethical perspectives as to how to go about this thing called telepsychology, right? And we've been in this game for a little bit, and I know we have a couple disclosures that we typically talk about. So I'll toss that over to you.
Absolutely. Well, we always like to mention that since this is a webinar about technology, inevitably something with technology will occur. So we just put that out there from the beginning. And we always like to disclose that we are ourselves telehealth educators and trainers in our professional lives. And I typically mention that I am a trustee for the American Insurance Trust Companies. Those are our disclosures. Anything else to add, Margot?
No, I would just add, though, you did mention that folks can drop their questions in the question section of the webinar today. But if between today and next time you have a burning question, you can certainly pop that into your evaluation because we review through those as well. Or you could email us at telehealthcommunity@trustinsurance.com. So there's lots of ways to get your questions to us. And maybe a great place for us to start today, Sarah, is with a little bit of newsy items and updates. How does that sound?
So newsy items and updates. First, I want to draw everyone's attention to in the chat window, you'll see information about the upcoming National Practice Conference, or NPC conference, in November of this year. This is an annual conference that's co-hosted by the Trust and the National Register, and frequently, topics related to risk management, frequently topics related to technology. So there's a great lineup this year. I encourage everybody to check it out. In other telehealth news, we always like to provide a little bit of an update on SIPACT, again, that interstate, interjurisdictional compact that facilitates psychologists' practice across interjurisdictional boundaries. This, of course, overseen by ASPPB. And in July 2024, South Dakota and Vermont are joining SIPACT. So if you're in those states, congratulations. This means we have 41 active member states in SIPACT, and then there's active legislation in other states like California, Mississippi, New York, Massachusetts. Some of that is contentious and some of it really isn't, so we'll see what all happens. But right now, I think there are over 11,000 psychologists who are participating in permission to practice across interjurisdictional boundaries through SIPACT. So it's something that's really taking off. And Margot, you and I were there in the early days of, talking about this compact, and I just think it's delightful to see it grow and thrive. Additionally, we talked on a prior chat about the United Health group breach, and just by way of reminder, in February, Change Healthcare, that's a healthcare reimbursement claims processing company. They had a cybersecurity event involving some ransomware. And there was a tremendous breach of their users' protected health information. And they are part of the United Health Group, which is a very large entity in the US. And I think a lot of individuals and practices have been uncertain of what to do with this information. It's been unclear who was impacted and what practitioners' obligations towards notification were. And while we can never delegate that responsibility, if we are aware of a HIPAA breach, we have to make people aware. It is notable that this month, July, Change Healthcare is going to start notifying people directly. So I think it's one of those things that we want to be thoughtful about communicating with our clients and understanding, who's been notified and who hasn't, if you think that your practice could have been impacted. And our last newsy item, I think this is just like a fun fact, and I don't know, to me, good sign for telepsychology generally. The FTC, the Federal Trade Commission, extended the health breach notification rule. So this is a rule that tells health covered entities that they have to report a health information breach. So for example, Change Healthcare, is governed by the health breach notification rule and HIPAA, and they had to notify their users of this information, and they're doing so this month. Now the FTC is saying, we're going to extend that coverage to health app developers, mobile applications that were not previously covered by HIPAA. So this is important because this means that those apps that are specifically storing personal health records, so some, information, patient's records related, has their PHI in it, now that app has a requirement to notify users if there's a breach. So I think that's a really good step forward, and to me is indicative of an environment that is, really being thoughtful about users' health and information. They're prioritizing it. They're changing the laws, to reflect that. So, I personally will be looking to see, which of those companies, what they develop and, what they offer, and, probably have a bias towards sending my clients to use, those products that does have that extra layer of security and thoughtfulness. I think that's our news for today.
Well, thank you, Sarah. We always strive to look through the content of the questions, the themes that we've talked about in the past, and also kind of where folks' questions are landing. And in doing so, we've taken last time and this time some focus to really do a bit of education in terms of some of the groups and organizations behind the world of telepsychology. And so today, I'm going to focus a bit of time on really going back to some basics in understanding the licensing process, understanding the organizations involved with that, and how the different groups that we have acronyms for really support us in our work in telepsychology. So I'll take a little time to do that, and we can dive into some questions related as we go. The first thing I really wanted to focus on was understanding none of this is possible without the licensure process. And that begins with your state or provincial licensing body. And it could be a board, it could be a department, or some other regulatory agency, but their great purpose is to protect the public, and they are authorized by whichever legislative mechanism is behind their initiation. And that legislature informs them of the work that they can do or what they have jurisdiction over. And they accomplish the processing and regulation of psychology through reviewing applications, reviewing complaints, determining who's eligible or has evidence to hold a license to practice properly and competently, and also what complaints might be processed through their enforcement systems. And their authority in terms of what they do is jurisdiction specific, meaning if it's a province or a state that is regulating psychology, they are able to do that within their province or state. It's not a national or international process. Related to telepsychology, then, there may be very specific statutes or laws that are surrounding the requirements or who can and can't provide telepsychology services within that jurisdiction or between that jurisdiction and another jurisdiction. And this is also where we would find these compacts that Sarah talked about in terms of SIPAC. There are laws then that get enacted within the practice laws or within the other laws of a jurisdiction that jurisdiction then has its determination of who is authorized for telepractice. So licensure and the practice of psychology really comes from each individual jurisdiction. And that's really what a lot of grappling was over when we started meeting with the task force for the guidelines of telepsychology. Was it 10, 12 years ago? And so one of the entities involved in that process was ASPPB, and they are the Association of State and Provincial Psychology Boards. They are made up of all of the psychology licensing bodies, and their mission is different to the psychology licensing boards within each jurisdiction. Their mission is to assist those boards in carrying out the legislative obligations to protect the public. So ASPPB provides programs and services to their member licensing boards. And that might include banking student or licensee credentials. It does include the development and standardization and validation process to administer and maintain our examination that determines our minimal competency to practice. And that's based on workforce analyses. And that helps reduce the burdens to the individual jurisdictions to manage that or maintain that on their own. And it also serves to increase national consistency, which, as we know, when we're trying to practice from different jurisdictions into another jurisdiction, in interjurisdictional practice is very helpful. They have had a certificate of professional qualification in psychology. They've had an interjurisdictional practice certificate in psychology. And these are all mechanisms that assist us in that practice from one state to another and consistency in understanding what our qualifications are to practice. The interjurisdictional practice certificate and the CPQ can be mechanisms that are used for folks who are seeking to acquire that authority to practice interjurisdictional telepsychology or to participate in that e-passport program that is what is rolling out through the compacts through each of those jurisdictions. There's great relationship here in terms of the work that ASPPB does to help support the work of the boards in helping folks in telepractice. And so you may have come in contact with ASPPB after you've taken the licensure exam because you may have a CPQ or an IPC or been part of that e-passport process. So they really are home for managing interjurisdictional telepsychology. The Trust is another organization that is a provider of professional liability, malpractice, financial security components for us as practicing psychologists, and really innovative risk management programs. And the Trust offers standard coverage for telepsychology plus trainings. And along with the National Register, they host the telepsychology competencies credentials. So in relationship to telepractice, there's a number of state-specific resources that you can dig through on their website, and those can include things for consent forms that are specific to jurisdictions or other document templates. There's a lot of webinars. There's our telehealth chats, and there's also the advocate program that helps us access consultation and guidance. And I'll speak a little bit more about that towards the end of today. APA, the American Psychological Association, they were the third group as part of those of us that met to really initiate the telepsychology guidelines. And APA is a professional trade association that supports psychologists. Their mission is to promote the advancement and communication and application of psychological science and knowledge to benefit the social improvement and improved lives of others. So you see a slight difference in the mission of APA, which is to promote psychology, versus the licensing boards, which are to promote public health and welfare. And in terms of the relationship to telepractice, APA is certainly part of those OGs in the guidelines development. They've been taking on the new telepsychology guidelines that Sarah mentioned, and it's coming to be presented in the annual conference this summer in Seattle. So those are forthcoming. Finally, I want to mention the National Register, and they're a non-government or a private sector credentialing organization for psychologists and psychology doctoral students. And their mission is to improve healthcare by identifying psychologists who meet specific educational and training standards that are set by the National Register, and they verify that information to consumers, healthcare organizations, and regulatory bodies. So related to telepsychology, they've been very active in helping co-sponsor the telepsychology competencies credential with the trust and supporting psychologists in their endeavor to navigate some of these interjurisdictional pathways that we are working on, helping provide services to more folks and access of care. So hopefully that kind of gives some guidance as to all of these organizations that really help support telepsychology, but from very different avenues and different missions.
Cheers. And Margot, those first meetings, those telepsychology guideline meetings, 13 years and 3 weeks ago. Who's counting though?
Oh my goodness.
We have a lot of great questions. Shall we pull some from here? I've already.
I would love it.
Okay. There's a great question. To your knowledge, have any telehealth practitioners been brought into lawsuits over telehealth practices? And the answer is yes. And my observation, I'm curious, what you'd add, Margot, two sort of divergent buckets, that I observe. One are those circumstances that occur in every psychological practice. So, things like standard of care, adequate treatment planning, privacy and confidentiality in terms of disclosing information about a patient, multiple relationships, inappropriate conduct. These are the types of things that happen in in-person practices. They can happen in a telehealth practice too. So, practicing remotely is no talisman against the types of concerns that people have in their practice in in-person circumstances. Then I think the other, sort of bucket I would think about would be those circumstances that are unique to telepractice, where people have had issues. And in those cases, I have been aware of kind of inadequate privacy practices heavily involving the technology. So, there's not an appropriate office environment, information breaches happening because the psychologist has not had an appropriate office environment and, are being overheard or seen and so forth. So I think that, and you start to get into some circumstances where there are things like technology issues, people have breaches. I think that's I'm not aware of the practitioner being sued, but I am aware of one telehealth service provider where they provided a video conferencing product and corresponding direct messaging product, and they had a breach and they had to do notification, and there were some subsequent lawsuits. So yes, I mean, there's all the things that normally happen to psychologists, in practices, and we can't, we're always beholden to those standards. But then there's that additional piece of being, additionally thoughtful about privacy, confidentiality, management of emergencies, all those things we talk about on prior chats. Those are the ones that I think add a layer of complexity in telepractice.
I would echo that and say, I think we're starting to see around the country too, some of the interjurisdictional factors at play as well. And so it's the same things that can cause challenges within an in-person practice, but when you add that layer of where are they located and not aware perhaps of what the emergency management or reporting requirements are in other jurisdictions, we're starting to see some challenges in those areas.
Let's see, I have
some other questions.
Yeah, do you want to pick one? I have another favorite.
I'll go with your favorite because I'm just perusing them as we're chatting.
I like this one. I feel like I can answer. Like, great. I'll get to the really complicated ones too. But when working through SIPACT and seeing someone in another state, am I correct that I will have to pay state income taxes in that other state? And my answer is probably. So I think individual states often have thresholds at which if you earn amount X, for days worked in their state. Now, I think a question historically had been, well, am I working in your state if I'm not in your state? But I believe that my best understanding is even with remote work now being, so democratized that, yes, they will come for their taxes if the patient is located in their state. The extent to which this is actually happening, I don't know. So that is something I couldn't really comment on, the extent to which people who have interjurisdictional practices are, really reaching out to notify that state of those hours worked. I don't know. But they may decide to file a state income tax return. But so I think it's one of those things, like, technically, yes, I'm uncertain of how often, it ends up being that way, though.
I think it's a great question for your accountants as well, and to leverage their knowledge of understanding your business practices, and also how you may be either receiving referrals or recruiting or advertising for your practice as well.
Great point.
Did you see any others, or do you want to move on to our next?
Let's move on. We're going to do two, and then we're going to do questions again, because there are a lot of really good ones. But I know we have a lot of questions from last chat that we wanted to be sure to spend some time with as well. During our last chat, we had, and this is not uncommon, I think, on many instances, we've had questions regarding artificial intelligence or AI. And I think just increasingly, this is a theme that comes up in telepsychology circles, which is interesting because in some ways it's telepsychology adjacent. You can have AI totally unrelated to telehealth, of course, but increasingly intersectional in the tools that help facilitate our telepsychology visits. And the thing I always like to emphasize is that this isn't unique to telepsychology. AI is increasingly integrated pretty much in any technology products we use. When I go to the bank, if I have a word processing document, if I use Excel, increasingly AI is present. So to me, it is not a question of if we use it, but really when and how we use it. And the call to be educated users of these tools who understand how they interact with information so that we can use them appropriately. There's a notion of prompt engineering, the idea of knowing the right words, to type, to say to AI to get the outcomes we want. And I think that's kind of relevant. Increasingly, we see psychologists using technology supported with AI to produce information relevant to our practices. So note templates, letters, other administrative information. We see some clinical intersectionality with note dictation and report writing. And additionally, many folks are investing their time, I should say, and a little bit of money in the development of a custom GPT, generative pre-trained transformer, this idea where you train it up to be an expert in a specific subject. So let's say I wanted Sarah GPT, I could go take every article I've ever published, I could upload it and say, hey, write me a blog post that sure sounds like me. It'd probably do a decent job. So I think we could really go down the rabbit hole for many hours on the ins and outs of how this may be used and whether it should be used, which I'm not actually opining on. But I'm really here to talk about the basics regarding how to uphold our ethical and legal obligations. So to me, there's kind of a rubric of consideration. Anytime PHI, protected health information, is involved, HIPAA applies. And so that requires us to really understand how a technology works, how they interact with data, how they store data, and generally their treatment of that PHI. And I don't know about y'all, but I do not feel that I am the expert to opine on how AI works. One day, perhaps. But I think that there are proxies for this. So for example, whether or not a product offers a business associates agreement or a BAA, that's a contract between a technology vendor and a covered entity for HIPAA, that's us, saying, yes, we understand that you have to comply with HIPAA, so we're going to comply with HIPAA. And we're going to sign this agreement with you that says we get it, we're going to follow the rules, and we accept responsibility, for this information and its correct handling. So this goes back to something, Margot, you and I talk about a lot, which is you might not understand the ins and outs of everything. It's really important to understand the fundamentals of how it's used and, to make partnerships with entities that are going to offer that BAA. So we have to understand it as much as we need to understand it's interacting, with the protected health information and then take steps accordingly. So, things like where is the data stored and who can access it? These are the types of things that they're going to govern. So a good rule of thumb, unless you specifically know otherwise, I sort of joke, assume that the AI tool that you are, interacting with is not using HIPAA, unless it has explicitly said that to you and explicitly offered you a BAA agreement. Presume that it is not HIPAA compliant. Treat it like a person who you are just talking to at random, and ask myself the question like, okay, here's someone who I know casually. Would I tell them my patient's address? Would I share patient records with them? Would I share patient social security numbers with them and so forth? If the answer is no, the answer is no. So I think it's a daunting vision of the future where I encourage you to treat AI like people. But I think there's something to it, to a rubric of just assuming, unless it explicitly says otherwise, we just treat it like someone we've met and we don't offer information, no matter how handy it could be in generating clinical notation and the likes. And as we get more facile with using these technologies, we want to be sure that we are double checking the work that it produces. Particularly, I know there was the debacle recently where Google told pregnant ladies they should really, really smoke during pregnancies. Turns out that's not standard advice. Who knew? Additionally, we want to disclose when we've used AI in a project, especially anything public facing. I really encourage ethically that we let folks know that we've used this technology to support our work. And I think we're going to get more and more specific as a profession as to what types of language, what types of prompts get us the best outcomes. I anticipate in the future, we talk a lot about the AI that's like integrated into healthcare products, it's integrated into our notation and record systems. But I think increasingly this is going to be our administrative assistant help. There's going to be a lot of things that we're interacting with as individuals that I think we're going to see a lot more bespoke solutions offered to us. So I think we're going to get a lot more savvy. The market's going to get a lot more savvy about how to create those highly customized GPTs and how to, have prompts that are really aligned with the outcomes we want to see. I'm going to stop there. We could talk about this for hours, but I think that addresses the general theme of what came up in our last chat.
And I think, Sarah, just to reiterate the emphasis of so much of us don't understand how the AI works, that if we're reaching out and playing with it, really making sure that what we're doing that is administrative doesn't include patient specific information or protected health information as we're attempting to see what it can do and what we can use it for. But then also making sure as we are incorporating this into some of our work products that we're citing that in the same way we might do for other colleagues' work that we utilize as well, and maybe even which version we're utilizing, as we know there's going to be more and more coming to the market.
So when I put on my blog that pregnant folks should smoke, I should definitely make the citation appropriately.
Yes. We've had a few questions come in, and one of them is about, do you know about Fathom? It's an AI that can join video meetings or records or produces summaries or transcripts. I know there's several of these kinds of products that may be integrated and claim to be HIPAA compliant. So do you have any maybe comments about the use of that for your practice?
Certainly. Yes. I mean, I think these are legion. I don't know about y'all, but most meetings I attend these days have like that eerie other attendee. It says like AI, and whatever the brand name is. It's certainly, again, I treat it like a person, so for me, it is just as I would not in a Zoom meeting, disclose patient PHI. I think not much has changed about the mechanics of that to me when it's not a HIPAA compliant product, I should say. Beyond the fact that now there's a record, so there's a record of what I said, which, I think it increases risk to practitioners that, somebody might in an errant, let's say, fashion disclose something they ought not to have. Well, now there's a written record of that. Again, am I aware of any precedent in which people have actually been having that type of issue? No, but I'm just saying practically that's the risk. Hopefully we're all not saying anything too scandalous. For those HIPAA compliant products, again, I want that business associates agreement. I'm shaded because I think, to me, if you really do comply with HIPAA, you understand the need for that documentation. So it's a marketing term. Do you really understand what that marketing term means? And then put your money where your mouth is and give me that document that backs that up. But yeah, I think they're handy. Anytime something like that is generated, though, consider where does it get stored? So what are the storage policies of the AI company? Are you going to take a copy, that arrives from that AI that is HIPAA compliant, and what are you going to do with it? It's creating more information for you to manage, may be very favorable. I can imagine, clinical interviewing and other circumstances where that's very useful, but it increases the necessity of my having a plan of how I am receiving, storing, and eventually destroying that information appropriately as part of the health record.
And I think one other piece I would add into that is reviewing their work product. And we see this consistently. We've seen this even when there's humans doing the transcription, that there are errors and it may not be exactly what you meant it to be. And ultimately, making sure in terms of both your ethical considerations, your clinical considerations, that you're not just signing off on things that you're not reviewing and reading, and making sure that, your name is really on that product, and that you're citing the use of that product.
I saw there's a follow-up question saying, I know that, or comment, that they do offer a BAA. And what do you think about having specific consent, for AI note takers? I think it's a great idea. Anytime you have any sort of transcript being created, I would want to disclose that in my informed consent explicitly. And this gets sticky, right? Because I think increasingly we're going to see integration of these products into a lot of the products we use. So if Zoom, we're meeting over a Zoom webinar today. Zoom has now a standard transcription product, which is ironically one of the things that gets disabled. If you pay for Zoom for healthcare, you actually will get fewer bells and whistles because you don't want that unless they offer, excuse me, I should double check, they haven't updated it, but as of a few months ago, they did not offer a BAA for that particular feature. And so it was disabled on HIPAA for Zoom. But I think that's going to change. And increasingly, we're going to see that optionality on products designed for healthcare, but think it through. And I think it's a great idea to have an informed consent. Yes. Especially if that's a meaningful part of your practice.
I think also in how you have this conversation with your patients is important. And I just mentioned that as a receiver of this in a physician's office who says, oh, my phone is taking the notes today. I hope you don't mind. That doesn't convey a opportunity to have a conversation or express that maybe I don't want that, even though I could speak up. How we're introducing this with our patients, how we're utilizing it, and why we're utilizing it, I think is a really important consideration as well. And there's no obligation for any of us to have a transcribed session. That may be part of a clinical research protocol. It may be part of a research component or consideration, but we've never had that requirement in terms of our clinical practice. It's our obligation to document the session in a manner that can support what we might be billing to an insurance, or to help us support the carry-on or carryover of treatment with somebody who may have to come in and help with the clinical care if, God forbid, something happens to us, or for the purposes of remembering what we talked about or where we got to in our treatment protocols. But transcribed every word is not a requirement. And so I think that goes back to what you mentioned earlier, Sarah, in considering why we're doing this and what the purpose is, and how then we're going to manage either holding, retaining, or just destroying of that information.
Well, we've started doing an ethical dilemma of the day. Margot, I think it's time for our ethical dilemma of the day part of the webinar.
I think it's a great segue. And we have had a few of these questions that roll in different chats. And we had one last time that was really good and too much for us to really just cover off the fly. So we thought, why not bring it up as our ethical dilemma today? And it's kind of part of the questions that we get and the complexity of the things that folks are thinking about, and we love it. So in a prior chat, we discussed some themes of interjurisdictional practice, patient non-compliance with the therapist's recommendations, and emergency situations arising. And a few people were curious, what if all of those happened at one time? How would we navigate that? What would we recommend in terms of, or how might we be thinking through this process of navigating this patient emergency? So I'll toss it over to you, Sarah, for some contemplations.
So if we're managing a patient emergency and it's outside our home jurisdiction, and we're managing an aspect of patient noncompliance. So, these are three really important components and valuable. Let's break them down a little bit and then think about how they intersect. So, all of these are larger topics than we will really give, a fair shake to, and encourage you. In prior chats, we actually cover in depth each of these topics, but let's talk about how they might fit together. In emergencies, we think of planning for an emergency as a part of informed consent and a part of intake. That's the same for in-person care as we do in telepractice. And we in telepractice are creating a bespoke emergency plan for each client. And the reason it's bespoke, it's going to have some information that's specific to telepractice and unique for each client, like the patient's location, the sort of emergency contacts local to the patient. We need to, of course, in advance, be cognizant of rules about emergency, and I'm starting to sneak in some of the interjurisdictional, we'll get there in a moment, and make sure that we are cognizant of who the patient's contacts are. Again, this is true for in-person care as well, but I really like in a remote care circumstance to understand, is there someone boots on the ground, proximal to where the patient is, who could help in an emergent circumstance that would be appropriate to help? I like to capture a release of information for that person in advance. I like to go over an overview of what to expect with my patient and say, okay, well, if a remote emergency would occur, what are the components of that? I would typically stay with them throughout the emergent circumstance, wait till emergency services respond, so forth, and let them know what would happen after they leave, because I can't go on the Zoom with them. What would follow-up look like, and how would we be communicating after the fact? I want to make sure that these clinical practices are consistent at the same high quality standard of care as my in-person clients, and that nothing's being too compromised secondary to being remote care. And as always, and as in remote care, in-person care, I'm documenting all of this. I like to have my emergency plan, as part of my informed consent documentation process, and having that reviewed with and signed by my patient. Now, if we are practicing interjurisdictionally, and I'm going to make a big assumption that we're practicing appropriately. We either have participated in the SIPAC compact, we've communicated with the patient locations board, and perhaps they have a mechanism that allows temporary practice into their state, or other mechanisms like that. So that's our first thing, making sure that we are licensed appropriately to be practicing, where we are delivering care. We want to be really cognizant of any conflicts that may arise between these jurisdictions and how that relates to emergency management, how you will handle them. If you are practicing in SIPAC, understanding any conflicts between your jurisdiction where you are seated and where the patient is seated. And this gets very relevant for emergencies. Is there a duty to warn? What are the rules regarding confidentiality and emergent circumstances? A rule of thumb to ensure that you are following the rules is to follow the laws of the patient jurisdiction. Of course, we should be following all laws. But I think people will say, well, what if there's a conflict, so on and so forth. We want to, even though my license in the state I am seated in facilitates my participation in SIPAC, my participation in SIPAC necessarily involved me agreeing to follow the rules of the patient location. So I think this is a circumstance where you're agreeing to follow the laws of the patient state, in addition to your own, of course. And we want to communicate those conflicts and potential adverse events, if we do think there is something, like let's say I'm in a state with duty to warn, I live in a state and practice in a state with duty to warn, my patient is in a state without. We need to call that out in advance and talk through with the patient what we would do, how that might affect them, so they really do have informed consent and understanding. We resolve this, beforehand. This is like nothing you want to be Googling in the middle of an emergency. It's just, to try to figure out what to do. This is the type of thing that forewarned is forearmed. And I really encourage folks to, for me also, patient safety, patient care is king. So, this is why I want to think about it ahead of time. Do I have a concern? Like what ethically do I think I should do for my patient's well-being? I want to think about that before the moment arrives. Patient noncompliance. Okay. So now we're having an emergency. It's happening jurisdictionally. We're following the home state's rules. But let's say that the patient is, struggling to help participate helpfully in this circumstance. They're very distressed. They're not following the rules. Let's say we need to conduct a welfare check, send emergency services to the patient location. We need to involve other professionals. This is a circumstance where most of us have been in practice, know there's tremendous variation in, the resources in communities. So this is where, again, being aware of the resources available to you and your patient in a difficult circumstance is very valuable. If I do a wellness check, well, do the police go? Are there mental health professionals? Are they in a facility where someone would, be a better choice to come and provide them that help? So being cognizant of who those folks are. Now there are some circumstances that they are, and again, before I move on, I should say this complexity increases if we are practicing interjurisdictionally, because again, we need to be really cognizant about laws regarding duty to warn, disclosure, and so forth. We want to be very cognizant about some of the limitations of controls. And I think there are many circumstances that may not be true emergencies involving patient safety, but sometimes we discussed, last time, it's just something that's inappropriate that's happening. And it could be something related to telehealth specifically, like a patient is not in the location we discussed. They're not in a private location. They can be seen, overheard. That's problematic. They've got people walking through the background. They're driving in their car. And, these are circumstances where, we really want to send a message that providers are not obligated to deliver care that ethically they don't feel is appropriate and aligned with their patient's best interest. We simply don't have to complete a session because we initiated it if we feel it is not good care and it is not in the patient's best interest. So, always we're not ethically obligated to deliver care we believe to be inappropriate. And this, this goes for all kinds of inappropriate behavior. We're talking about inappropriate behavior specific to telehealth, but it's also true if someone were to grow verbally abusive or be inappropriate with the clinician or be intoxicated in the middle of the meeting and it's not something that was previously agreed upon and contracted for. Those are the types of things that, may fall under that rubric. So, okay, I hope we covered a lot of the intersection of, emergencies and it's interjurisdictional and we're not getting cooperation in the matter. Forewarned is forearmed, I suppose, is the big takeaway. And
well,
so,
and that's, oh, go ahead, Sarah.
Oh, please.
I was just going to say that really is a great segue to some questions that come up for me. And when those questions come up, like, gosh, if I need to call law enforcement, who do I call? Do I call someone in my jurisdiction or do I call someone in their jurisdiction? And do I still have immunity if I do that interjurisdictional breach of patient confidentiality? And so these are the questions that segue me into thinking about who would I call in this circumstance to navigate some of these conflicts or some of these concerns, to have an idea ahead of time what I might do to reduce my risks as both a professional, but increase my effectiveness in terms of helping my patient within that situation or that circumstance. And I don't think we could say enough thinking through this ahead of time, talking about it with your clients ahead of time, and reaching out to your colleagues, especially those at the risk management and the advocates at the trust, because they really are a fantastic resource for us as clinicians out in all the jurisdictions to be able to get some very specific answers about how we might navigate a particular situation in our jurisdiction versus a particular situation in the patient's home jurisdiction, for example. So in preparing to reach out to those at the trust, I thought it might be helpful for you and I to talk through a little bit about what happens when you make a call, because I know we've both made the call, we've both scheduled, and we've both gone through this. And I think one of the most important things is to know when you call the trust advocate risk management number, it's to schedule a call with someone. So your first call is not to Ghostbusters. There's not going to be an advocate right there to answer that burning question that you've worked yourself up to really make the phone call. It's to schedule a call. So hopefully that can help relieve a little bit of stress about that first call. The number is 1-877-637-9700. You can find it in the website. I know they're going to drop it in the chat, but this is the number where you will call to say, I have a dilemma happening, or I'm curious about this, or I'm thinking about doing X, Y, and Z in my practice, and I would like some guidance. And so it could be you're calling about a clinical conflict, an ethical dilemma, a business issue, a boundary issue. You need consult in terms of other ways to think about a challenge. And so you just want to give them a little bit of that information, not the whole thing. They just need to know a little bit about what you're calling about. And so then you'll get your appointment time set, and then you can prepare for the real appointment call, the Ghostbuster call. And what you're going to want to be thinking through for that is what your ultimate question or two that you need to have an answer for is going to be, and write those down so you can kind of maybe refine them a little bit before you actually get on the call. It's a brief call, it's 20 minutes, but it really is enough time to review those critical background key aspects of whatever the situation is. You can note some of the things you've already thought about or considered, or maybe some steps you've already taken to resolve a situation, or you might be thinking about taking. You can talk through some of the things that you consider, any research or analysis you may have done or contemplated. And make sure you have any key documents available that you might need to refer to for the call, and a notepad and a pen to take notes. There is no AI bot going to transcribe that call for us. It is for you to write down and take your impressions from. And on the call, you'll be talking to one of the 7 advocates. Be sure that you have the phone number, or you have the phone that you've given the phone number to, because they will be calling you at that number. And they will kind of walk through this process. They'll ask what you're needing to have an answer for. They'll review some of those high-level details of the situation. And you'll have an action item by the end of the 20 minutes. You might not have a detailed answer to everything, but you will have an action item. It's a super valuable tool. I know I have been grateful to have this access throughout my career. Sarah, is there anything that you would add to the experience with the advocate calls?
It's a great overview. I mean, I think the only thing I'd add, because you did, you said it all, is I try to think about, because when you make your appointment, as you said, they're going to ask you, what it's about, and you'll tell them. But personally, my time, I have so much time scheduled on that call. And, the risk managers the advocates are in demand. And so I try to be really thoughtful about what are the, 1 to 2 things I really want to have answered in that call. And, we're psychologists, we're really good at agenda setting, and try to, really communicate, these are the top 2, things, facets of this I want to make sure we discuss. And that helps me get the most out of my call as well.
Fantastic. Have you seen any questions in the chat as we've been going through?
There's so many good ones here, and please know, again, we're not going to get to all of them, but we do read them. They're, we really take time and talk about them. So thank you. There are quite a few in there about international practice. And so I thought maybe we'll just speak a moment. It's an oldie, but a goodie.
Yeah.
International practice is sticky because, plainly said, there is increased risk when we practice into a jurisdiction where we are not licensed. And in the tricky business is, if you think about it from a public health protection standpoint, we want to make sure the consumer has some route for redress, should a problem occur. And if it occurs out of the country, and the care didn't occur in this country, the regulatory board of my country may or may not even accept that, complaint, and there is no mechanism, to complain about me in another country. And I think what's notable is how diverse, it's a big world, treatment of the psychology profession is elsewhere. In some instances, in some countries, we are still licensed practitioners. In others, we are not. There would be no board to connect with regardless. So generally speaking, the highest risk managed perspective is to not engage in international telehealth. I will acknowledge that people do it. And I will share with you that if you would go back and look at some of our risk management roundtables, which opine on this subject as well, the way they talk about this is like, well, the probability of having an issue seems low, but it is very dependent on the case. Is this a steady, stable client who's just on vacation for a moment, and wants to have a check-in? Is this someone who's in an emergent circumstance and now I'm, and they're moving there forever and I don't know anything about the country they're going to? Those are very different circumstances with very different risk profiles. So, my feeling is I've seen it done in circumstances with very low risk clinical cases. That being said, I think the highest standard is to understand anytime I'm not licensed somewhere, I don't practice into there. So that's the most risk managed position we can have for the protection of our own practice, our well-being, and our patients' well-being. And sometimes people do.
And I think just to kind of add on to that, understanding what the requirements are in those other locations where patients are is so important for some of the things we just finished chatting about in terms of patient safety, patient welfare, how to navigate, how to manage those circumstances if they were to come up. Because, our reason for wanting to work with patients within those other locations that they travel to, it really tends to be from that good-hearted service provider space of helping them out and doing good things. Yet we may not be doing the best for them if some of those conflicts are such that either we would be putting them in jeopardy or our own practice in jeopardy to do so.
It's a great point. And I think, people should be cognizant of the fact that, malpractice coverage typically, and this is, true about all malpractice coverage, doesn't cover where we aren't licensed. That's just the nature of that coverage. So if we're practicing inappropriately for the license, if I set up a surgery tomorrow, my malpractice doesn't cover my new surgery practice. If I started, working again, and contrary to my license, then I can be in a situation, where if a problem emerges, I am less protected. Again, like, have I heard of it happening? Yes. But I really agree, like, understanding the specifics of the circumstance would be, before we even consider something like that, really important.
And I think another great conversation to bring up, both with your colleagues, but also with those in the know and at your risk management advocate office. So,
shall we take one more question?
Sure. Do you see a good one?
I see lots of good ones. Let's see. Here's a great one that's sort of relevant. Is it possible to do couples therapy with the identified patient being with me in the office and the spouse being in another state who's being seen via the same session in telehealth? Great question. And generally speaking, in couples therapy, where both clients are regarded as the couple, we want to have them both in a place you are licensed. So let's say you're a SIPAC state holder and you are in your state, and one patient, one member of the couple is in your state, but the other member is in another SIPAC member state. That would be a circumstance where that would work. Or you had contacted the board of that distant patient location, the outside of jurisdiction patient location, and made arrangements with that board, to do it thusly. If, however, they were somewhere that, you had no mechanism, to be licensed where they were seated, I think it gets problematic. I've heard people do interesting things here where they said, well, no, the second person wasn't the patient. They were a collateral reporter. They were just there to share some information about my patient who I have a HIPAA governed relationship with. To me, it's kind of a sticky business. I would probably, I understand what they're saying and I understand the loophole that exists there, but I think they're more likely to have trouble than not. So, my feeling is we practice where we're licensed and we make sure that, where the patients are seated, we have appropriate licensure.
And I would say, just to add on to that, we could say the same kind of thing about custody arrangements where parents are in different jurisdictions. And, I think probably don't have to mention too much about that being one of the challenging areas of practice, but making sure that you have a license and understand what the requirements are for that other jurisdiction is going to be quite helpful to you in making a determination of whether you're going to accept that other party into that patient session. And again, not to say that these things don't happen, but having forethought about it, having consideration about it. There's been a number of questions asking, do I have to have paperwork specific to the state in which the patient is located? And yes, the answer is yes. And just as you mentioned, Sarah, sometimes those requirements can be conflictual. So you really do want to understand what you're obligating yourself as a practitioner to, and what you are telling the patient from that other or sitting in that other jurisdiction that you are able to do in terms of practice. I'm looking through. I don't know if there's a short one we might squeeze in before our time is up today.
Let's see. It's this one. This one's short and sweet, and I like it so much. Working by SciPact, this person has met with a client with a traveling job within the state. Appreciate you clarifying that. But often meeting in a car. And, and so should I get the license plate number? I think yes, that's what I do. I always joke that if you had told me pre-pandemic that I would be meeting patients in my car, I would be like, I don't know. I'm not so sure about that. I think so many of us face circumstances where our patients could not find privacy in their homes because everyone was working from home, children were learning from home. I really feel like it moved the needle on something where that I want to make sure that we're saying a stationary car because I feel that it is unsafe to do therapy with folks while they are driving and not appropriate. But if they are seated, what I will typically do is I will ask them to give me the location of where they are. Sometimes they give me very specific geotag locations, but often it's cross streets, and they'll give me a landmark. I will ask for the make, model, and description color of their car, and I ask for the license plate number because I want to imagine, they're having cardiac arrest or they're really having an emergency and I need to send someone to help them find them. I don't want to be saying, oh, it's a car, it's brown on the inside, I really want to have crisp, concise information I could share with emergency services to get them the help they need. Great question.
I think you bring up a really important point too, that not all emergencies that may come up in telepsychology relate to the clinical aspect of care in terms of, the therapy they're engaged in. It could be that, the car, somebody had an accident into their car. It could be that they were having a medical situation at that time. So even though you might not anticipate the emergency to be related to your clinical care, it is something that presents itself as an unusual circumstance in terms of not in the office, right? And so thank you for that overview. I think I'm just so thrilled. We get so many amazing questions, Sarah. It's always so fun to chat with you and hear perspectives and really get to contemplate some of the fun questions that we get. Thank you so much.
Thank you, Margot. This is just a consistent delight. I always appreciate hearing your perspective, particularly your depth of knowledge on regulatory concerns. And I appreciate everyone coming here and spending their time, which is their most precious resource, with us. And I appreciate all the great questions. Please know we really do spend time with them and think about them. Thank you. I think it's time for us to start.
Yeah, I was going to say, in summary today, I'll kind of wrap up and chat just real quick about the content that we covered today. We thought we'd try and do a quick summary. We've learned a deeper understanding of the organizations and agencies that support our professional practice in psychology. Sarah talked about the factors to consider in inviting AI into your practice, either in the preparation of materials for administrative use or clinical services, or as it relates to ways that you might need to look into that from a third-party services perspective. We talked about an ethical dilemma today that focused on factors related to interjurisdictional practice and navigating patient safety and welfare checks. We talked about a role play of calling into the trust to seek some consultation. And we covered several awesome questions. Thank you so much for all of your engagement in our question box on the line.